title for today is Developments, Critical Issues, and Impediments in the Training of Physician Scientist Workforce in the United States. Um, and these are our conflicts of interest. So I will turn it over to Emily to talk about our learning objectives.
All right, so thank you again for inviting us. So the learning objectives for today is to recognize the key trends in physician scientist training, including funding, mentorship, and career pathways, to understand the challenges, including diversity gaps, mental health, and balancing clinical and research roles, to learn about new on-ramps for postgraduate physician scientists interested in research training, and the challenges retaining physician scientists during the postgraduate training period. So the overview. So first of all, we're going to highlight the importance of physician scientists and identify what the key challenges are that they face. Secondly, we're going to explore the initiatives that improve retention, enhance diversity, and streamline training, both on the UME and GME side. And then we're going to discuss future strategies and how to sustain and grow the physician scientist workforce. And I will hand it back to Talia.
Great. So we'll start off talking about the critical role of physician scientists in medical innovation. And so for everyone to sort of define a physician scientists are blending clinical expertise with research skills and allowing them to directly translate scientific discoveries into patient care. And there's an overlapping Venn diagram, and there's a huge spectrum of what physician scientists are doing in terms of the areas in which they're pursuing their research and the extent to which they're participating in clinical medicine. But we're going to be defining it in a very broad sense and talking about these sort of multi-layers that go into the training of these individuals. As we think about physician scientists throughout medical history, this is sort of a overview of historic figures who have really set the groundwork for modern medicine in terms of developing antibiotics, antiseptic surgery. You're familiar, and we use the sort of discoveries and work and contributions of these individuals every day. What you'll notice from this list is a profound lack of diversity over the history of physician scientist contributions, and really underscores the need for us moving forward to recognize this gap and recognize what are those sort of barriers that are holding us back from diversifying the field. But to say that the contributions of these scientists based on their clinical expertise has been really critical in informing innovations and continues to be a driver of how we're able to move the field forward. In terms of the path, it's a lengthy one, and we'll talk about this a lot, that there are many different stages of this training from undergrad, and there's sort of a higher and higher burden to have preparation as an undergrad such that you can transition to either an MD or an MD PhD student or other clinical or dual degree training. After that, residency and fellowship, and then this term that has sort of fallen out of favor, which is controversial, the zombie zone, which is in between the completion of GME training and transition to junior faculty, which is marked by that transition to independence in funding and publications, where mentorship is really critical. And so across this this continuum, there's multiple themes that will come up over and over again about what's sort of allowing for individuals to be successful to make it through, and what are the factors that are driving attrition. As we talk about the training, we'll talk about UME and GME. When we talk about UME, we're talking about either candidates who are going through an MD PhD program or an MD program. And in either of these cases, the idea of training physician scientists relies heavily on research as part of that. So if it's part of an MD, perhaps you're doing a scholarly year, maybe you spent a lot of time during summers, and maybe that remains part of the work that you want to do during your residency and fellowship. And we'll talk about some on-ramps that would allow for that. And then the MD PhD program, which is built for this, which is a dual degree program that many of you are probably familiar with, which is on average sort of across the country an 8-year program that integrates a preclinical or pre-clerkship component, a clerkship component, post-clerkship component with graduate school in between. And students will complete both degrees in this 8-year average. And the PhD across the country is in many different types of fields. And so there are a lot of sort of social science PhDs and other sort of biomedical fields and outside of that. And this is an area that's growing sort of around the country and sort of all the different disciplines in which you might pursue a PhD. Adriana, do you have a question? Maybe.
Sorry.
Oh, no problem. Did you have a question?
No,
Okay.
just a mistake. Sorry.
No problem. Excellent. So this is sort of the UME, and I will hand it off to Emily to talk about GME.
Yeah, so do feel free to ask questions if you have any along the way. So this is from the GME side. So this is just the structure of the research pathway within internal medicine that you may or may not be familiar with. And it's different depending on the specialty that people go into. So pediatrics has a different structure to medicine, but I'm just going to kind of focus on this one. So in medicine, we have two traditional ways that you can go through. The bottom is the categorical track, which essentially is where the residency is the 3-year internal medicine residency, and then people go into fellowship afterwards. And we'll talk about it a little bit later, but traditionally this is kind of the MD pathway. And if people become interested in research, it's often at the end of this fellowship period where they end up having exposure to research, possibly for the first time, having a dedicated research experience during fellowship. And this is kind of what we've considered the traditional late bloomers. The pathway that more commonly the MD PhD graduates go into is this research track. And so for back in the 1990s, the American Board of Internal Medicine came up with this pathway. And the idea was to shorten the clinical training so that people who knew they wanted to pursue a research career could then get more quickly back into the research, into their research and advance their career. So for this pathway in internal medicine, it's 2 years of internal medicine clinical training. A lot of people get confused thinking it's going to be a research period during residency, but in actual fact, it's actually just condensed clinical training. And then they do the 1 or 2 years of clinical fellowship, depending on the subspecialty. And then there are 3 dedicated years that are required in research. And the last one can be as an instructor. So there is dedicated research time in this pathway, but it's important to realize it's not during the clinical training, and trainees do need to get the dedicated clinical training before they can get back into the research. Funding is always an issue, as Talia had mentioned, and we'll come across it again, is this kind of dedicated funding that is needed to kind of transition people from the end of this fellowship training during the zombie zone of getting from fellowship to junior faculty. And then there is this other step beyond that that we'll come to again, is this transition from being a junior faculty member on a career transition award, which is a K award, into the R01. And I guess for people who aren't kind of living in the space of NIH funding, it's just when we talk about these K awards, the K award is traditionally an award that goes to an individual, usually a K08 or K23 for MDs, being the K08 is traditionally more the physician scientist bench researcher, and the K23 is a clinician scientist award. And so these are the awards that are NIH funded that get people from their fellowship to their career independence. So what are the challenges that are faced then? So the path, as Talia mentioned, is very long, and unfortunately, it is getting longer despite certain initiatives to try and shorten it. There's a profound need to broaden the diversity of the workforce, and there's an attrition through the pathway that remains a major problem. So why is the path getting longer? So unfortunately, every step in this pathway is getting longer. And so historically, people would do their undergraduate and then would go into the MD PhD programs. This gap here, this first gap, this time to matriculation, is ever extending. And if anybody's reviewing the applications for the MD PhD program, you can see that there are an incredibly number of very well qualified and overqualified, if you like, people going into the MD PhD program where they already have years of research experience between their undergraduate and their MD PhD. And so Miles Acabas and Skip Ross co-authored this paper based on in 2022 in JCI Insight, and it basically looked at the ever-extending number of years people are taking. So previously it used to be maybe 1 year between the undergraduate and the MD PhD. Now it's kind of extending up to 2 and 3 years quite commonly. And so this period just to get into the MD PhD program is lengthening. The second place it's lengthening is actually within the MD PhD programs. And so again, a number of years ago, people would do maybe 6 years in the MD PhD program. Now it's traditionally 8 years or possibly longer. And so there are questions, if people have all this experience before they even get into the MD PhD program, should there be kind of a different metric of how they succeed in the research part during their PhD? Like, does that actually have to be 4 to 5 years of a PhD to get through that program? And then from the residency and fellowship side, again, despite certain initiatives to try and shorten the residency program, like the ABIM research pathway, this period between residency and fellowship and this intermediate zone between the time that people get their first junior faculty position is also extending. And typically it is this phase that is extending between them finishing the clinical training, getting more research experience, and obtaining a junior faculty research award. So this is just showing you that data again on the gap between the undergraduate programs and the MD PhD. And so you can see here basically between 2012 and 2020, the percent of people who were doing gap years is basically increasing almost, not quite exponentially, but increasing dramatically. And then and also the number of years in the paper, you can also see that the number of years people are actually taking as a gap is increasing. And so it's actually become more and more the norm that people do not go straight from undergraduate into MD PhD training. And so this is one place that there's been a focus on looking at why this is lengthening and can it be shortened. And then the other piece of important information is this time to first independent award. So this is defined typically as time to first R01 or R01 equivalent grant from the NIH. And this is sort of the metric of independence. And so you can see if you go back, this is data from the early 1980s, essentially the people who were getting their first R01 were in their mid to late 30s. The purple line here is for the MD PhDs, and then the green line is for MDs only. And so you can see essentially it's been increasing to the point that now it's 46 years of age by the time people are getting their first R01. And so this is the time often when people get their first actual faculty appointment beyond being junior faculty. And so this is an issue for many reasons. One is that obviously the longer and longer it takes for people to get their first independent award, this is more likely to be attrition on the way. The second thing is the years of productivity. So if it takes you until you're 46 to actually establish your own research lab, obviously your years of being productive and having an independent career are greatly diminished. And so again, there's sort of been initiatives to try and figure out how to reduce the age to the first R01. On the bottom here, it's the number of years that it takes to get from medical school graduation to the first R01. So if you think of residency and fellowship training, is residency maybe for medicine is 3 years at most, and fellowship training maybe another 3 years, but it's actually taking 17 years from medical school graduation for MDs to get their first R01 and 13 years for MD PhDs. And this was data from back in 2014 from the NIH physician scientist workforce that was put together this data at the time. And so this is actually even longer in the last 10 years since this report went out. So one of the initiatives of the Alliance of Academic Internal Medicine Research Committee is to sort of look at these issues with regard to postgraduate training specifically. And so last year, we looked back at NIH Reporter, where you can get a lot of publicly available data on people who were graduating from medical school and how long it was taking them to get their first K award, because we're trying to understand why is this time to R01 lengthening. If it's partly obviously these gap years before people do go into MD PhD programs, but as I said, we can also see this 17 years, up to 17 years between the time that they graduate from medical school and they get the first R01. So there's something that's lengthening this process. So what we wanted to know is how long it's actually taking for people to get from medical school to their first K award, which should be their first career development award. And traditionally, if you talk to people like who applied for Ks maybe 15 or 20 years ago, they would say that they got their K award during fellowship. But if you kind of talk to people anecdotally now, there's less and less frequently that's happening. And so we wanted to kind of put numbers on this. And so we looked at the K awards, both K08 and K23s that go to physician scientists. And we looked at people specifically in internal medicine. And then we looked at the IK2s, which are the VA equivalent of the K award from the VA supported sites. And so essentially what we found was that it's now taking MD PhDs just over 8 years to get from their medical school graduation to their first K award. And again, if you calculate the maximum time they might spend in residency and fellowship training is probably up to 6 years, maybe 7 years in some specialties. But essentially, there's a gap here that is a problem because this unfunded gap, essentially, where people are finished their fellowship GME training, but don't have the support yet from the K award. For the MDs, it's a little longer, and this might be surprising that it's only 1 year longer, given that MD PhDs already have a significant amount of research experience from their PhD. And so it is longer as expected for MDs to get from medical school to their first K award, but only a year longer on average than it takes people for the MD PhDs. In the VA system, it's interestingly shorter for the MD PhDs, and there is some question about whether the people who are reviewing these grants at the NIH versus the VA have a different perspective on the experience of the MD PhDs and how much extra training they need before they are eligible or qualified to get a career development award. So there is an interest now in looking at study sections and how they're reviewing career development awards for MD PhD graduates.
Great. So for all of these reasons, there is this urgent need to broaden the diversity of the workforce, but also to sort of recognize all of the pieces that are limiting it. So in general, physician scientists constitute only 1.5% of the total physician workforce and are declining. The average age, as you heard, of both applicants and graduates is increasing. And as we look at the percentage of matriculants who are underrepresented in science and medicine, it's very small and only modestly increasing. And there are significant recent data that have come out to suggest that physician scientists who are underrepresented in science and medicine are at high risk of attrition. And so we really need to look into this. And as we've talked about, the length to training is a big part of it. But there are also a bunch of other things. So this pipeline is leaky at each of the stages, as Emily said, that are lengthening. These are also nodes where people are leaving the pathway. So as we talk about why, there are a whole bunch of different categories of why people might not want to continue in this path. Reimbursement is lower than it might be if you're in a clinical position. There may be a paucity of mentors, either physician scientist mentors or physician scientist mentors that you can identify with. There's significant minority tax, especially for those who are representing multiple different pathways. So physician scientists who are finding themselves in clinical spaces, research spaces, their own identity, they may get pulled to be on numerous committees and participating in institutional initiatives, bias and discrimination, and caregiver responsibilities that we will talk about as we talk about the training pathway getting longer and longer. People are living lives and want to start families, and it becomes really challenging to do that at these critical career junctures all at the same time. And so all of this is compounded by this longer training time. And so there are more and more opportunities at different stages to exit the pathway. So what can we do? We can do a lot. Since there are so many different areas where there are challenges, we can work to streamline this path. And so we talked a little bit about that, and we'll talk more. We can address gaps in recruitment and retention of trainees who are underrepresented in science and medicine, and then we can work to identify general areas to improve retention in this pathway. So in terms of streamlining the path, this, as Emily described, this idea of like nearly 80% of the MD PhD matriculants taking gap years pre-matriculation, are there ways that we can, on sort of a national level, reduce that, or at least get the message out about understand why this is happening and what we can do potentially to decrease that? Talking about across the country, the development of sort of curricular innovation and what can be done to reduce the time to degree. And then streamlining postgraduate training to independence. So reducing gap year. So one of the major initiatives of the AMC Great MD PhD Communications Committee that was developed about 15 years ago to expand outreach to MD PhD programs and sort of get the word out has been sort of taking up this mantle about whether gap years are important. And the what that paper that Emily was just talking about, that Miles Akabas and Skip Brass published, is about why people are taking gap years. And a significant number of applicants who are taking gap years are taking them because they were advised to do so, but they didn't necessarily need to on the basis of their research experience. And so this is part of the slide deck that's used by program directors around the country to give guidance on whether or not, if you're a current undergrad thinking about whether or not to take a gap year, these are some considerations. And so, yeah, if you don't have significant research experience, you haven't delved deeply into a project, you don't have familiarity with testing a hypothesis, or you feel like you need more time just to decide if full-time research as part of a physician scientist career is something that you want, those are compelling reasons to take a gap year. But other people are getting advice that they should take a gap year because A, it would make them more competitive, or B, they need to have publications, or someone just told them this is the thing to do, and you would be viewed as a at a disadvantage if you didn't. Those are not good reasons to take a gap year. And there's a national dialogue around MD PhD program directors about this, about sort of evaluating candidates within the context of the exposures that they've had. So it doesn't count against you if you're coming straight from undergrad. We just need to understand what your exposures have been, and whether you've, done a senior thesis, whether you have, delved deeply into a project. And so then if you are going to take a gap year, how to engage in research such that it's substantive. So this is one thing. It will be very hard to measure in the long term whether this sort of national marketing initiative is effective. But another very important node is communication with the pre-health advisors that tend to not be very familiar with MD PhD applications. And so some schools that have lots of applicants each year are going to be much more well versed, and others don't really know. And so that's another initiative, is speaking to the pre-health advisors about what constitutes strong candidacy with respect to research and whether gap years are appropriate. Another area is the development of UME curricula to reduce time to degree. So this is a study that a group of us did this year in looking at, as curricula are being developed across the country with the move to triphasic curricula, what are MD PhD programs doing relative with their PhD relative to the pre-clerkship phase, and sort of sitting for step one. And then ultimately the question which remains needed to answer is, what does this mean as far as time to degree? So it turns out that MD PhD programs around the country have three basic structures, where either the PhD, either it's sort of broken down by whether there's a long, medium, or short pre-clerkship phase. So if it's long, it's 2 years or more, which is what our legacy curriculum had been. Medium is 13 to 18 months pre-clerkship, which is our new Ascend curriculum. And then a small number of programs, about 7 with MD PhD programs, have a 12-month pre-clerkship phase. And then there's sort of different breakdowns as to where the PhD phase, this big blue, happens. And the trend is that the shorter the pre-clerkship phase, the more likely clerkships are to take place before the PhD. And so either that's like here, where the clerkship phase takes place in its entirety before the PhD, or here where there's a partial pre-clerkship phase, which is actually what we're going to be implementing with Ascend. And so this is all very interesting, but we don't have outcomes data. And so one of the big topics for discussion is, how do we then use these structures to inform what's happening in the programs? And so is it that's doing clerkships earlier might help to inform a PhD and potentially reduce your time to degree? The jury is out on that, but these are some initiatives that a lot of people are discussing. And I will turn it over to Emily to talk about more streamlining.
So from the GME side, then, the question about streamlining the residency and fellowship clinical training program has been actually controversial for a number of years. And the main reason, again, is trainees go to different people for advice. And actually what has been happening traditionally is that in many institutions, when medical students go to seek advice about whether they should do a 3-year residency or a 2-year residency, they're actually told that they won't get enough clinical experience and clinical training over the 2 years. And this has been a kind of a bias and a piece of advice that has been hard to get rid of over many, many years. And actually ABIM looked at success rates in passing the boards and people who did a 2-year internal medicine residency versus a 3-year internal medicine residency. And it turned out that people who did two-year residencies in the ABIM research pathway had at least as good, if not better, pass rates for the boards than people who did the three-year residency. And so there's really no evidence that physician scientists who are clinically strong coming into the program and don't have major clinical concerns can't do 2 years of internal medicine residency, at least with the outcomes of board pass rates at the end of it. The other issue that has I think we need to discuss as a GME collective between residency and fellowship programs is, whether fellowships believe that the 2-year training is enough to get into competitive fellowships. And so now, kind of similar to internal medicine trainees across the country, there is a tendency for MD PhD graduates to go into 3 major subspecialties, one being cardiology, the second being gastroenterology, and the third being hematology oncology. And these are very competitive in all, in between MDs and MD PhDs. And so the question is whether, fellowship programs believe that the MD PhD graduates who go through the ABIM pathway are strong enough clinically to enter their fellowship programs, and B, if they are able to support the trainees in the research part of their fellowship training. And so the other challenge for many fellowships in many institutions is that the fellowship programs rely on some sort of training award to cover the time, again, in this transition period between finishing the fellowship and reaching the junior faculty stage. And so the support part here is a reason why sometimes people are not accepted into residency programs that are part of the ABI research pathway, because the institution does not have the ability to fund them or support them in this transition phase. And so this is sometimes why people end up getting kind of funneled into the 3-year residency versus the 2-year residency program. And this is a challenge. So then this is kind of, again, the motivation behind this paper that we published just earlier this year on whether it's time to reduce the postgraduate training for internal medicine residents. And so essentially what we were really focusing on was this transition phase again, or this, as Tally had it, as the zombie zone, but this phase where you're kind of neither a fellow nor junior faculty and you're waiting to get your first K award. And so this ever lengthening time here is a national issue, basically. As I mentioned, there's a question of whether the K award study sections, the people who are reviewing these Ks, have kind of unrealistic expectations of people who trained as clinical residents. And there is this tendency that people, even if they had an MD PhD and even if they had publications from their PhD part, that they actually need to have yet more publications during the fellowship training in order to be competitive for this K award. And obviously, if somebody goes back into basic sciences, is one, if they start in a new lab as a basic scientist, no matter how much training they had or how many publications they had during the PhD, the reviewers are expecting another publication, which can take easily 2 or 3 years in a basic science lab to get out. And that may make them less competitive or lengthen the time until they get this K award. The other issue is from the institutional perspective, in that somebody has to support these people through their training. And so the reason that it's important to know the current the current timelines in people getting from medical school to K award is that if institutions are interested in supporting physician scientists, they need to know that they will need to have some sort of financial support and able to be able to get people from the fellowship to the junior faculty position. The other thing is that some of the NIH institutes are coming out with new mechanisms specifically for physician scientists. So the Infectious Disease NIAID Institute has actually brought out a Transition to Independence Award, particularly for fellows who have MD PhDs, in order to get them more quickly from the fellowship phase to that independent R01 phase. And some of the other institutes, like the National Cancer Institute, are following suit, in that they're having awards that are very specifically for MD PhDs to try and to reduce this time of transition and this junior faculty phase to independence.
Great. And so as we talk about addressing gaps in recruitment and retention of trainees who are underrepresented in science and medicine, we can think about sort of at the beginning and the end, or sort of across the continuum, about how we can expand awareness and access for prospective applicants, and then what we can do to sustain that and broaden the diversity across the workforce throughout this training continuum and then beyond. And so there are a few different areas in terms of the access issue. So, as I mentioned, the AMC Great Communications Committee has been really working to get the message out through collaborations with conferences, with pre-health advisors, with APSA, which is the American Physician Scientists Association, which is a student-run organization with tremendous advocacy. And in building this organization has built a ton of virtual resources for both creating competitive applicants for MD PhD programs, but also just sort of getting the word out. And these are some slides from the talk MD PhD is a right for me, which is available to all program directors through the AMC to go and talk about the application process, training, careers. And then there's this very slide that says why there's an imperative to diversify the physician scientist workforce. And so this is a sort of an area that always needs better understanding of how to sort of expand access and how to talk to folks earlier and earlier, because what we're seeing is that if you hear about it as an undergrad, it's almost too late if you haven't had exposure to research and you don't know. And so how can like the K through 12 level get sort of hear about these careers and also exposure to mentors across the continuum. So this remains a really important challenge and big initiative that a lot of folks are trying to think of creative approaches. And then talking about broadening the diversity across the workforce. So NIH has been sponsoring a bunch of initiatives, one of which Sinai is a site for, the NIH First program, this concept of cohort hires who are faculty at the junior faculty and senior faculty level, who are committed to diversity, equity, and inclusion across biomedicine, with the idea of investing significant institutional resources to have communities of folks who are role models and active researchers and contributors to the institution, to really increase representation and provide this community of practice across. And so Sinai is participating in this, a bunch of programs around the country, and NIH has a bunch of different programs that are to sponsor faculty at different levels to sort of retain and support. And so then if we talk in general about retention efforts, we can think about these three things that remain challenges once sort of training is over, but also during training. So recognizing the role of families and parenting during training, enhancing mentorship and support, and then thinking about ways to be flexible in training pathways. So the recognition of the role of families and parenting during training is something that really no one ever talked about before a couple of years ago. And there's been driving momentum that has led to NIH providing a childcare subsidy, which is a great start. It's a tiny effort, but is a great start. And that is that any trainee who is appointed to either an institutional or an individual training grant, so either a T type award, T32 or the like, or an F type award, is eligible for what used to be $2,500 and now $3,000 per cycle for in childcare subsidy. So it's a lovely effort on the part of the NIH to commit to this, but it's really tiny. We live in New York. $3,000 is not really sufficient to maintain childcare needs, but it's a good start. And we actually put out this paper last year about the importance of recognizing physician scientist trainees with parenting responsibilities, because we have learned that this is a powerful deterrent from people even considering the path. Thinking about if you're graduating from college, maybe you've taken gap years, the idea of committing to an 8-ish year training program and then what comes after that and wanting potentially to start a family makes it seem like this is an impossible choice. And so in here, this was a effort led by a bunch of different programs, including students who have childcare responsibilities, and came up with these 5 general pillars of action to support parenting during physician scientist training, having institutional policies to clearly outline how leave policies work, lactation support, childcare options for trainees, healthcare, dependent healthcare subsidy or coverage, and then financial support that would be kind of in the vein of what the NIH has started, that small subsidy, but potentially institutional matching and even encouraging the NIH to increase that, and also for unrestricted funds, because right now it's pretty restricted and limited to those who are specifically appointed to the training grants. Um, Then, as we talk about enhanced mentoring and support, so there are a lot of efforts around the country, including NIH mandated. This is a new part of the new training mechanisms to require mentor training for all faculty who are participating in NIH funded training grants. And a lot of programs, including Sinai is doing through the Office of Faculty Development about culturally aware mentoring, and SIMMER and related training programs that are really emphasizing mentor training, which is something that has historically not occurred. People are excellent scientists, excellent teachers, but not necessarily having the training in mentoring. And that is challenging when you're mentoring lots of folks from all different backgrounds with different goals. And so it is really important to have a rigorous sort of evidence-based approach to that, which is really picking up and is in fact, now required. So all of our graduate school faculty have to participate in mentor training. And then I will hand it over to Emily.
All right. So as Talia mentioned, so part of the issue with diversifying the physician scientist pathway is that a lot of people, as you saw, have to do these gap years. They have to have it planned out long in advance of actually getting into an MD PhD program to make themselves competitive to actually get into that program. And so another issue that is close to my heart, being a very late bloomer, I would say, having done clinical training in Ireland and the US before I decided I wanted to be a researcher, there are these new R38 grants that Rena mentioned that we very recently have from both the National Heart and Lung Blood Institute and the National NIAID, which is Immunology and Infectious Diseases. And these are basically to try and move the arrow here that you see on the top line of the traditional late bloomer who may not figure out that they're interested in research until they're actually a clinical fellow to a little bit earlier in the pathway. And so the R38 or STAR awards are stimulating access to research and residency. And they're really aimed at people who might have an interest in research, but actually never had the opportunity to have that research experience either during medical school or by getting into an MD PhD program. And so this is aimed, one priority of this is to attract people who are underrepresented in science and medicine into the pathway. And really what we're planning, we have this now, it's shared between internal medicine and pediatrics, and we have our first 2 residents join the program in July of 2024. We will have up to 4 spots per year between internal medicine and pediatrics. And the way it works for internal medicine is that actually it will lengthen the internal medicine residency training by 18 months, and residents will have the opportunity to do 18 months with 80% protected research time during PGY3 and PGY4 year. And the idea is that that basically lays a strong foundation for them to be able to go on to develop a physician scientist career. The residents who are accepted into the R38 program are residents who match into our categorical residency program. So they basically come in as internal medicine residents in the categorical pathway, and then we kind of give them some information about the STAR pathway during their intern year, and then they have an internal application process during their second year. And then, as I said, it's during the 3rd and 4th year of residency training that they will actually have this 18 months of protected time for research. The other big advantage for the residents themselves is that they actually are then uniquely eligible to apply for a K38, which is like a fellowship research award. And so this is an individual K award that they can actually take with them to any fellowship program they go to, whether it be within Mount Sinai or externally. And only residents, as I said, who actually were R38 residents are eligible for the K38. So it's a very limited competition. And so there's really a good opportunity here for people who didn't have the previous opportunity of doing an MD PhD program or didn't have a scholarly year during medical school to really get a good foundation in research during residency and fellowship. As it's a very small cohort of people, they're also very much individually mentored by the MPI team on this R38. And it can be any sort of research that they can do. So it can be anything from basic science to clinical research. It can be health policy. Literally anything on the spectrum of research is okay for the R38 program. I guess I'm doing the conclusions as well. Or no, Talia, are you unmuted?
I'm happy to we could share. Well, so I guess in sort of wrapping up, we sort of underscored the importance of physician scientists in playing this role in bridging gap between research and clinical training, and that's critical to driving advancements in innovation, but there remain really key challenges in retention, lack of diversity, and the need for streamlined training. So we talked about a lot of strategic initiatives related to mentorship and support networks, increasing diversity in recruitment, and then adapting training to be more flexible and efficient. And looking forward, the idea of what we can do as a community, as an institution, and more nationally sustaining and growing this workforce in building innovative approaches, continued support, and targeting strategies to address the challenges and ensure the success of future generations. And so, with that, we are happy to take questions, and thank you so much for your attention.
Thank you, Talia and Emily. If you minimize your slide